DBS is launching a new product and they would wish to display a 2-minute video. So can we have the video? All right, so let's move on to the post-break session. And for this, can I please ask again Vaya sir to join us on stage, and also the next chairperson, Dr. Alka Subramaniam ma'am, to please join us on stage. Ma'am is my teacher, and it's amazing to introduce her. She's a professional additional at TNMC, multiple awards, I can't even name them, more than 25 years of experience. Ma'am is currently the president of the IAGMH and Indian Psychiatric Society EC member from 21 to 24. Yes. Okay. All right. Thank you. So let's move on to the next session. Is this slide moving? Yep. Our next session is by Dr. Paresh Doshi sir, and he's going to talk to us about DBS, ablative surgery, and neuromodulation for psychiatric disorders. May I please request the chairpersons to please welcome and introduce our speaker.
Dr. Paresh Doshi sir, I'm supposed to introduce you. I think that will be a presentation for half an hour by itself. We won't do that. He is the pioneer of neuromodulation in India. After extensive study and experience overseas, he began introducing the topic from the very ground level, telling us the primary alphabets of neuromodulation. He has now come to a stage where he is going to be soon the president of the World Association of, Dr. Paresh, is that right? World Association of Neuro...
No, World Society of Stereotactic and Functional.
World, just why don't you tell them?
It's okay. World Society of Stereotactic and Functional Neurosurgery. But I think that all happens, yeah. Thank you.
So, he's more an international than a national figure, but fortunately for me, I would say we are still personal friends, and you'll still know why. Dr. Paresh?
Thank you so much. It's always pleasure to listen to Dr. Vaya, who has, I think, one of the strongest supporter of what I was doing when I was also exploring myself. And thanks, sir, for that encouragement and always including this encouragement of putting this particular program together. First of all, I would like to thank Prashant and Prajakta both for putting on a lot of effort. And also, I'm very happy to see the turnout of young psychiatrists, including the senior psychiatrists along with them, to listen to the neuromodulation in psychiatric disorder. And let me tell you from this platform, and mind my words, 5 years down the line, and I have seen this change happening with movement disorder specialists and neurologists across the country over the last 30 years. It has not been a new thing for me. When we started neuromodulation for movement disorders, it was looked at very great skepticism because it was invasive. You are lucky. You have an armamentarium of yours which you can practice in clinic, which is a non-invasive neuromodulation, which is reversible, which has no long-term side effects. What better treatment option one could have? Even drugs have side effects. So when you have that, why not to look into that and understand and explore the science behind it? Okay, so we heard fantastic talks from nationally acclaimed speakers on non-invasive neuromodulation. I'm going to dwell a little bit in invasive neuromodulation, but before that, I thought I should address a couple of questions that were raised earlier. So we started functional neurosurgical department in 1998 at Jaslok, which was one of the first of its kind. And 3 years back, we have developed a department of restorative and regenerative medicine, which also includes non-invasive neuromodulation as one of the armamentarium. My passion is neuromodulation. So anything happening in neuromodulation field, I would like it to be brought to India. And there will be many new things coming in the next 2 years, as you would see. This is a special department which we have created, which gives a feeling of a spa. It is not giving a feeling of a medical clinic. This is within Jaslok Hospital. This is a waiting area and a special treatment room from Deep TMS. We have all the 3 coils that Dr. Tirthali mentioned, H1, H7, and H4, because we believe that we can't try to have a non-customized solution. We should have a completely dedicated customized solution. Not only that, we have got sham protocol programs included within this coil. So if I am doing a research study, I would be able to give a sham stimulation using the same coil, same method, same tick, 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 tick noise, but not delivering the stimulation. So then we can have a properly randomized control trial, and we are right now conducting a completely free randomized control trial for exploring the efficacy in migraine and cognitive disorders. These are the scores. Someone was asking about the outcome of the Deep TMS, and these are the scores of Deep TMS at Jaslok Hospital on MADRS and HAMS both. And same thing for OCD, we had almost 92% response rate. And this is a long-term data of published by a group also has conflict of interest. This group was supported by Brainsway, the company which makes this Deep TMS. And hence, you can take it with a pinch of salt, as Dr. Tirthali mentioned. But there is a long-term efficacy known to this. So coming back to now invasive neuromodulation. Who has ever thought or considered neurosurgical option of medicine refractory OCD, depression, and Tourette? I'm asking very specific question, OCD, depression, and Tourette. Has anybody thought in this audience of considering neurosurgical option? I want a raise of hands. So probably 5, 6, 7, 8 people, and some of them from the institute and some senior doctors who are very well informed. But yes, so because this is not known, or this is something not, who thinks that this can be practiced in India? Again, it will be from the institute. Yeah, it would mainly from the institute because they are exposed to that. At the moment, there are 3 centers, probably 2. Third is PGI Chandigarh is not yet doing it. Nimans and the Jaslok at Bombay are only 2 centers who are practicing this. So I don't mind because people would not know about it. What is the strongest barrier for invasive neuromodulation in India? You are not sure about the right candidate, you are not sure about, convinced about the outcome, or you are worried about the risk of complication, cost, or all 4. I need some response. I can't just have quiet, silent speakers. So what do you think is the main barrier for not considering? Okay, let me ask you a question. Not convinced about the outcome?
The main barrier is
But why? Why? It is there. So when in incomplete information, that means risk of complication or not sure about the outcome, correct?
Not even sure of the etiology or
The indication, fair enough. That is interesting. So this very quick presentation, I would review the literature of DBS and lesioning. There are two methods of doing invasive neuromodulation versus deep brain stimulation, and I presume that people would know about it, but basically it implants electrode and connects to the pacemaker. I have not got a slide for that just now, but basically it implants electrode in the brain and connects to the pacemaker, and it's considered to be reversible because you deliver stimulation through that. And second is lesioning, wherein you do either a gamma knife, that is a radiosurgical lesion, or you put a radio frequency probe and ablate that some spatial group of cells, or now with the latest technology available, MR guided focus ultrasound, with the help of ultrasound waves, without opening the head, without making a hole on the skull, you can use focus ultrasound stimulation to destroy that. Then I will discuss what has happened in India, and then I would talk about some personal data. So this is something very interesting. This slide has, I've taken some help from the AI also. So the last part is AI generated, but this was published in 2017. And there were 3 different periods. One was the frontal leucotomy period, where there were a lot of publications. Then it fell down because of a disrepute, because of the bad reputation about a leucotomy and word leucotomy. Then in 70s, stereotactic, a precision neurosurgical procedures came into place. Stereotaxy means a precision neurosurgical procedure. And again, people started getting interested, but it was available only in select centers across the world. And then deep brain stimulation came, and it started accelerating slowly, following the deep brain stimulation. And now you can see that the third wave, or the third generation, is rapidly expanding. Depression. So we are talking about a very, I would say, upcoming science. The science is building up as we develop experience and expertise, and that is why if you see the target, you can see there are almost 8 or 9 different targets in the brain, and you would say that if you are not knowing which target to target, how can we trust the efficacy? So the reason is that, as Dr. Vahia mentioned in his introductory remark, we are targeting circuits. So all of them are connected through one or the other circuits in the brain. The largest experience is in subcallosal cingulate gyrus, where this is a corpus callosum on an MRI, and at the base of the corpus callosum, where the subcallosal cingulate gyrus comes, that is where we target. This evidence had been presented by Professor Helen Mayberg way back in early 2000s, and they showed that this CG25 is hyperactive in patients of depression, and after 3 months of continuous deep brain stimulation and 6 months, as you can see on this PET imaging, the area turned blue from the red. That means showing the response. These were the early results, as I said, early 2000, and you can see that there was a 40% had more than 50% reduction, 5% of them had remission, and at 12 months, the scores further improved. And you look at the long term, 75% of this group, which is an open label study. So open label studies have to be taken with a slight pinch of salt as compared to the randomized trial, but nevertheless, they are an objective study. And there was a significant improvement, and you can see that the improvement continues in cases of depression and deep brain stimulation over a period of time. This is a recent meta-analysis of 11 studies of 189 patients, and they said that there is no one target fits all approach, and the future of DBS is going to be personalized. This is the effect size. Effect size of more than 1 is considerable, of significant effect size in meta-analysis, and you can see that at long term, the effect size swayed towards supporting the outcome of deep brain stimulation. And as I said, we talked about network. This is what we are doing recently now. There is a confluence of this. You can see this SCC25, this area, and all these beautiful colored diagrams are the white matter tracks. So cingulate bundle, forceps minor, uncinate fasciculus, all of them where they confluence or join together, that is where the node is for stimulating. And when we can identify this track, so this is a personalized DBS. This can be different in every patient. It could be 1 or 2 millimeter difference, but that makes the outcome difference. And this is what we have done in the last couple of patients. We come to OCD. I'm going to rush a little bit because it's not going to be possible. Otherwise, the target for the OCD is going to be the anterior anterior limb of internal capsule. So this is the anterior limb of internal capsule, IC. This is internal capsule, and this is the anterior limb, and the posterior limb of internal capsule is the area where you get motor fibers. So interior limb is completely safe. The work originally was done by Bart Newton and his group in Belgium, and that was taken up by several other centers as a randomized study. And this 25 patient study got the OCD DBS and US FDA approval as an accelerated treatment protocol on a humanitarian device exemption, HDE. It is called HDE because we don't have so much data to make it a mainstream thing, but it is still, it can be offered for patients who are refractory. So they found that Vibox improved by 54%, 75% had more than 35% reduction in Vibox after DBS, and these are severe refractory OCD patients. Vibox ranging beyond 22, 24, even more. So along with, we all know that depression goes concomitant with OCD, and depression scores also improved and anxiety scores also improved in these patients. It was found that patients with religious and sexual obsessions were better responders. Older age of onset was a better response predictor. No significant difference seen between different targets. No significant difference seen between aggressive checking, behavior cleaning, and asymmetry. This is the graph of a recent meta-analysis as late as 2026, showing that more than 400 patients have been analyzed, and DBS proves clinically meaningful symptom improvement in carefully selected patients with severe treatment-refractory OCD. Coming to Tourette, there have been lesser studies, 162 cases reported, 6 or 7 targets. The largest amount of work has been done, centromedian parafascicular nucleus of thalamus, and pallidal GPI. We perform in pallidal GPI. We have some reasons for it. Again, if it was a dedicated talk on that, I would have gone into more details of the science behind it, but we perform this, and this is where we go. We go now to a lesional surgery where we make lesions in the brain. Same type of outcomes, cingulotomy and anterior capsulotomy were most practiced, and this is not a new thing. It has been practiced for more than 50 years, but only select centers. For example, Massachusetts General Hospital has 800 cingulotomies for depression since 1962, and very good response rate, up to 50% improvement, and also very little side effects. Similarly, from Dundee, another group reported in a paper 20 cases with 55% improved and 35% unchanged, which HMD score having more than 50% reduction. This is a gross slide of the recent data. I used AI to generate it because I didn't have time to put all these things into one place, but you can see that the pooled response rate is coming to the same 50% response rate. When it comes to OCD, anterior limb of internal capsule is a preferred target, and this paper shows that if you consider, these are paper analysis before and after, before the Vibox scores were reported correctly, and some patients' papers did not report Vibox. So if you consider no Vibox score reporting, almost 86% papers said that their patient improved. Again, these are all case series because none of the cases have been very large series enough. So they are meta-analysis and pooled data analysis. If you consider Vibox as has to be a gold standard for reporting, then gamma knife versus radiofrequency lesioning both had similar outcome of around 60%, 65% plus. Again, a complex slide. We can't explain the details of that, but in the given time, basically. But 75 studies with 1259 for OCD only, considering deep brain stimulation and ablative surgery, and they could not find much difference between DBS and ablative surgery, nor they found significant difference. They found RF, radiofrequency ablation, as a very important technique. The second question came here. We discussed and asked about complication. This is a recent paper that we have authored as a multicentric group, comparison of neuropsychology. And this paper showed that our findings suggest that the neuropsychiatric surgical interventions associated with neuropsychiatric disorder are comparable to or even lower to than observed in epilepsy, neurovascular, and neuro-oncological surgery. So the complication rate is high is a wrong, false myth. It's just because our knowledge is not there, we are facing that. Taken together, these results suggest that concerns regarding neuropsychiatric surgical intervention in contemporary may be exaggerated and most probably should not consider. And this is not my conclusion, this is a conclusion from the journal editors. We come to India. The work for this started way back in 2009. You will find Dr. Vaya here, looks much different than today, but nevertheless, his coconut remains the same. So it's about the coconut, and many other people would find themselves here. We had a first consensus group meeting, and the guidelines for surgery was published as way as 2009. And still, it was not possible for us to create a great amount of awareness. Basically, that time the group agreed that we should only restrict it to DBS or surgical interventions for OCD and depression. Similar task force was formed at a World Society level in 2011, 2 years after we did the task force. And then this task force came up with a paper on a consensus guidelines in 2014. The follow-up paper on OCD, specific OCD, because by 2021 we had more data available for OCD surgery. Also, the US FDA had given this approval for surgery. So we came up with another guideline paper, Deep Brain Stimulation is an emerging or an established therapy. There is a legal paper also if someone is interested to understand and see that how the world sees this around the world. And this is again a multidisciplinary paper from all across the world, which we have contributed to. In 2018, we conducted a larger conclave than the 2009, and here again, a lot of people here, Dr. Tirthali and many other people were there, Dr. Grover were there. All of them joined for developing some guidelines or outline or roadmap as to how do we develop these surgical techniques in India with full safeguards and full precautions so that we can make sure that it doesn't go out of disrepute the way it happened in 1950. And then this paper has come out. Now this paper is considered to be the gold standard or the main paper for adopting invasive neuromodulation in our country. And you can see that the signing of this paper, there are so many co-authors, and all of them are acknowledged also as a part of this erratum. This paper has come out with 3 different sets of guidelines, and anybody interested should refer to this: OCD, depression, and Tourette syndrome. Unfortunately, in 2017, Government of India passed the law that you can't perform this surgery in even hospital setup. You have to have a state board to give you an approval the same way the kidney transplants or liver transplant boards are there. It took me 4 years and persuasion to the government of Maharashtra. We had to take them to the High Court to get them to form a board. And the High Court gave a judgment that the Maharashtra state should form a board for psychiatric disorder surgery, and then the board was formed. And after that, we got the permission and we performed our first DBS for depression after a hiatus of 6 years. So coming to criteria for depression, because that is what Dr. Vaya mentioned, that we don't know whom to refer and how to refer. So these are very strictly laid down stringent criteria in conjunction with the top psychiatrists of our country. All you saw the names on the paper. So we should have a strong diagnosis of depression, current episode lasting for 12 months and more, response to multiple treatments should have failed, adequate dosage and duration of each has to be tried, that has to be documented, failure or refusal of ECT has to be documented, and actually it is 20 ECTs that has to be documented. If you go to the Indian guidelines section, you will find it more detailed. And as you can see, the SDRS score should be more than 20. So severe depression and functioning should be significantly affected. Same thing for OCD. The criteria in the bar for Vibox has been raised to 28, and they should have failed all therapies for major therapies for OCD, drug treatment, and behavioral therapies. So it is not that any patient or every patient can be offered this. It is only after establishing a significant amount of refractoriness that one can be offered. So this is around 18 patients we have operated so far. Average age has been around 35 years, 9 OCD, 5 depression, and 3 Tourette, 1 with autism who had a behavioral problem, and that is why we offered. We go to the OCD results, 6 lesion. 3 capsulotomy, 3 nucleus accumbens lesioning, and 1 nucleus accumbens DBS, 1 BST DBS, and 1 VCVS DBS. So several targets based on the evolution of science. Ybox changed from 39.6 to 8.4. Highest Ybox was 40 in 2 patients, and minimum improvement was 50%. HAMD changed 24 to 6. This is the lesion that we used to do. You can see a lesioning in the anterior limb of internal capsule, but as the science improved, our lesion became very small. So I had to put a red dot here to show you the lesion. The size of the lesion became very small, and it was now at the bottom of the internal capsule. The white thing is the internal capsule, and now it is in the bottom of the internal capsule, and to be specific, nucleus accumbens. This is the video of the patient before the OCD.
Now tell me, what are your major obsessions?
Without contamination, frequent washing of hands, without contamination, I want to wash. Asking the same thing again and again. If somebody comes, checking whether he is done correctly or not, checking things again and again.
How many times you want to check?
Once I start checking or testing it, I cannot stop. It goes.
And this is him after surgery.
Any obsessions now or obsessive thoughts?
No.
Not now.
No.
Okay. And write your name. Sentence. After how many years you must have signed? So you signed last in 90.
transaction foreign application
Thank you for
She signed after 15 minutes. We reported also side effects of the surgery. Need 2 minutes more, 2 to 3 minutes. Yeah, we can cut down on the discussions. Yeah, the side effect of this has also been mentioned and reported. So it is not always that we want to report good things. All the wrong things also has to be reported. This is the first patient in the Asian and Australia continent who came from Australia for depression surgery. We targeted SCCG 25. I will skip the slide of this. This is showing why right on the operation table the impression or the improvement in his depression, but we'll talk about after 3 years, because people would like to know what is happening at 3 years.
Hi, my name is Ben Ward. I struggled with depression for over 5 years. I tried about 15 medications, I had electroconvulsive therapy, and nothing was working. I was just getting worse and worse. I was really suicidal. And yeah, I had no options left in Australia. And that's when I heard about Dr. Doshi's deep brain stimulation surgery that's being done in India. And then I sent him an email and contacted him. And yeah, then we went over with my parents, and I had deep brain stimulation for depression there. That surgery, it worked so well. It saved my life, and I'm 100% better now. I'm not taking any medicine, and I got married, and yeah, I'm working, and yeah, life's great.
So this is the results for depression. Significant improvement, 5 cases. Tourette syndrome, I won't go into the result, but results have been exemplary. You will see it for yourself, the video. This is the patient. And this is him after surgery.
Hello, my name is Jitendra Sethi, and it's been 2 months of my operation, and all the Tourette syndrome symptoms are under control.
And the last is autism. Just you can see that this patient was suffering for 42 years, and I'm not recommending this surgery for autism, but this was a serendipity. 7 years later, she has been rehabilitated. This is a 7-year follow-up, celebrating 7 years after surgery. Thank you. Oh, before I end, sorry. This is a very big meeting coming up next year. Mark your space, take a picture of this. You may want to be a part of this if you are interested in neuromodulation. This is a big international meeting that we are conducting next year, and I would like to invite everybody. Thank you.
Thank you, Dr. Doshi. The questions, please.
We have about 6 minutes.
Incidentally, those 2 photographs of psychiatrists from India includes Dr. Dave, who was at
Yes,
both
yes.
the pictures.
Yeah. I couldn't take all the names. There were
I think we can take about 2 or 3 at the most. Yes, Dave sir, please.
This was around when I was a houseman at KEM 1967, where at that time leucotomies were done after giving ECTs, not in KEM but at other centers. That you give 3 ECTs, confuse the patient, leave the upper eye, and then it's a nail-like leucotome, sterilize and put it on the both sides, and the leucotomy is done. I had seen one patient where the leucotome has broken and had remained inside. So such a crude surgery was performed at that time. And then I think 1998, and like he had shown in the graph, that even Niemann's, where the psychosurgery was performed, there was a lot of opposition and they had stopped doing it. And 1998, I believe, when you came, you started in Jaslok Hospital, there was a combined meeting where Dr. Paresh Doshi had started doing it again. And there were so many doctors who were trying to oppose at that time. But he persistently continued, and Jaslok Hospital became a primary center for stereostaxic surgery. And there again we started developing interest in Bombay, and some of the patients we started, and now there are guidelines. And I think he's persistently doing this work and progressing a lot in this. The best wishes.
Thank you, sir.
Long ago, 1973, I was a house physician when Jaslok had that Henson's cingulotomy ring, and one of our patients from KM was taken for cingulotomy for alcohol abuse. He continued drinking but would not get intoxicated. From there we've come a long way now.
I don't think we should be recommending that for sure. Yeah, Jalpa has a question.
Sir, I believe you all have the Deep TMS machine in Jaslok Hospital. So what is the journey for the patient? I mean, who decides the motor threshold?
Very interesting and important question. I was just talking to Dr. Dave. Unlike invasive neuromodulation, for invasive neuromodulation, we require the involvement of the in-house psychiatrist because the patient is going to be there for 10 days. This is an OPD-based practice, and in our practice, we see neuromodulation as a non-invasive neuromodulation, the deep TMS or RTMS, as a complementary add-on treatment, not a substitution to the medical treatment or other forms of behavioral therapies or any other treatment. So the psychiatrists who are handling, so every patient that we are doing has to have a referring psychiatrist. If not, we ask the patient to connect with their doctor, make sure that doctor, sometimes the patient says our doctor is not convinced about it, then we can ask them to talk to the in-house psychiatrist. But most of the time we try to talk to the referring doctor or the treating physician because he has the best understanding of that patient for 10 years, 5 years. There is no point in digressing. The only other place where I have found this, and I have seen it very effective, is in the childbearing age group, female of childbearing age group, because they would like to get off the medication, and that has been, we have been able to get several of them off the medication, off psychiatric medications following a successful treatment.
So is it the technician who determines the motor threshold?
No, my neurosurgical team. There the neurosurgical team gets involved. So my team gets to determine it. And because it's a H coil with a full helmet with fixed parameters to fix, the chances of error are very little in administering it. The administration is done by a very senior specialist technical nurse. She's been there for 3 years now. So she does the administration, but the determination is done with the help of a neurosurgical resident.
So one last question. Any experience with patients who have dyssynergic defecation, who have OCD and they are fixated on their bowels and all for hours, they need to go to the...
Yeah. Thank you. So, thank you very much, Dr. Doshi, for that very informative amount of research that has come from India. And I would like to formally also thank BPS for having me here today. It's a pleasure to always come back on home turf. And the next session is actually going. Sorry.
Can we please felicitate?
Okay. Sure. Sorry. You're doing it in the middle of the session. All right.
Can I also request Dave sir to join us on stage to felicitate sir?
I want to clarify, my sticking to this chair is not a sign of my perseveration. I was asked to do that because the previous chairperson didn't come.
That's a sign of your wisdom.
Thank you, sir. Let's move on to our next talk, ECT in Psychiatry, Evidence, Modern Techniques and Practical Application, for which we have none other than Dr. Sandeep Grover, sir. May I request the chairpersons to introduce, sir, please?
Yes. So, thank you, Prajakta. So we are changing the formats a little, so apologies, you all had to jump back and forth. And after the whole morning on TMS, we go back to old is gold. And for that, we have none other than Dr. Sandeep Grover, who's, of course, very well known to, I think, everybody pan-India from PGI Chandigarh. His forte is in CL psychiatry, emergency, as well as geriatric psychiatry. And he's one of the few top 2% researchers awarded by the Stanford University. And I think that deserves a round of applause because it's a pride for the nation at large. And why did he get this? Because he has more than 1,000 publications, which is, all of you know how long a cycle life for a single publication is. So it's really, really creditable. And on a separate note, which is not written on that entire introduction and the slide, we started our careers together. He's the president-elect of the Indian Association for Geriatric Mental Health. So all of you have not registered for Geron, do it now and watch him becoming president in September, 1 month to go. And we both have spouses who are ophthalmologists, so we share a lot beyond just psychiatry. Over to you, Sandeep. Thank you.
Thank you, Alka and Sir, for the kind introduction. And I'd like to thank the BPS team for inviting me here. Please bear with my voice. And is the slide changing? Not changing with this. So, in terms of conflict of interest, I'll just disclose that I have used AI to generate my slides in terms of the images, but the content I take the full responsibility and I am aware what I am using. And in today's world, we talk about different generation and we are talking about generation Z and everything. So, if you look at that, if you look at the history of neuromodulation, ECT, when I say ECT, it belongs to a silent generation, and you will see that it's a treatment of silent generation, but which is persisting and nobody can still compete with that. And when we look at the history of ECT, it came in 1938 as a treatment for treatment with severe mental disorders, and soon we realized that it is one of the most efficacious treatment for management of severe mental disorders, but way it was given initially, it brought in a lot of stigma which we are still fighting till today, and despite being the best treatment in psychiatry, it still has a lot of associated stigma. However, although 88-year-old treatment, nobody can compete with this treatment. Whatever modalities we are talking about, nobody comes close to the treatment. So, we started as unmodified ECTs and gradually we have shifted to the modified ECT. And In the modified ECT, we have brought in the general anesthesia, we are trying to monitor the seizure duration and so on to make the treatment more safer. And over the years, what has been the refinement in the treatment is that there is no doubt about the efficacy of ECT anywhere, but is the problem with the cognitive deficit with the ECT. So, the whole effort in improvement in the technique of ECT is reduction in the cognitive deficits associated with ECT. That is where we are moving about. And the current understanding that it is a very, very evidence based treatment which is life saving, effective in patients with various treatment resistant conditions, especially the severe mental illnesses, and it has been continuously refined to overcome the cognitive deficits, and it is a hope for millions of people around the world. With this brief introduction, I will now come to what is the kind of brief which was given to me by the team, what I should be speaking about. So, in terms of patient selection, the simpler thing to understand, there are no absolute contraindications for giving ECT. In today's world, there is no single contraindication that we can say that if patient has this, you cannot give ECT. ECT has been given after, let us say, about a week, 10 days, 1 month after myocardial infarction. It has been given with patients with brain tumors and so on, everything. So, there is no absolute contraindication in terms of giving ECTs. So, it should be considered whenever it is needed, and but we need to be very careful to follow all the due procedures, because we understand, because it has a lot of controversies and lot of stigma attached. So, we as practitioners need to work on this, so that the people do not go back with more stigma associated with ECT. Now, coming to the indications and the modified ECT. So, we need to understand that how the different indications are changing over the period and how we are refining the ECT treatment. So, in terms of the indication, the traditional indication for ECT are depression, schizophrenia, mania and catatonia, and many of these patients ECT is very, very life saving, and we are using these method of treatment in patient with treatment resistance and those who are having suicidal ideation or at a risk of death in terms of not eating food or so on, or catatonia which is not responding to lorazepam. And what are the recent emerging indications for ECT? So, a lot of data is emerging in terms of use of ECT in patients of dementia. Although we talk about that ECT leads to cognitive deficits, data is emerging for use of ECT in dementia patient, but we need to understand it is not for improving the cognitive function, it is for management of comorbid depression, comorbid catatonia, and for management of when we talk about the comorbid aggression and agitation. So, there is data emerging for that, and this is where we need to understand, and similarly for use of ECT in psychosis. And if you look at the data for frontotemporal dementia also, again there are a lot of reviews which are coming in, then where we talk about the improvement with ECT in these group of patients, you will see that the response rates again vary for various symptoms in terms of behavioral symptoms, manic symptoms, depressive symptoms and so on. So, ECT is emerging as an option for management of behavioral symptoms and other issues in patients of dementia. And this was another review which came in last year, again which mainly focused on Japanese data, where again they showed that ECT is being quite frequently used, and in this survey of the various institutes in Japan, they showed that in about 2/3 of the institutes, the ECT was being used for management of behavioral symptoms in patients with dementia, and they had used in about 134 patients during the period of about 4 years. So, that is where we need to understand, when we are struggling with treatment resistant behavioral symptoms, maybe you may consider ECT if you are looking at the so called indication beyond what we understand as the general indication. Again, when we talk about, Dr. Doshi was talking about use of ECT in the movement disorders and everything, there is a lot of data for the use of ECT in movement disorders as well. And again we see that ECT is useful in patients with Parkinson's disease, and it is beyond the so called only improvement in depression. It also leads to improvement in the movement disorders and so on. So, this is where we need to be very be thinking about considering this as an option in patient with movement disorders. There is some data in terms of use of ECT in the tics disorders as well. The results for Huntington and other things are not very encouraging. Again, PTSD. There is a lot of talk about PTSD and people are evaluating RTMS and tDCS for PTSD. Again, some emerging data suggest that ECT may also be beneficial in patients with PTSD, and which is not just limited to the benefit of depression. It actually takes care of the so-called core symptoms of PTSD, and that is where when you are struggling with so-called complex PTSD and treatment-resistant PTSD, if you have no other options, you may think of considering ECT. But again, I will say that whatever the newer things which I am discussing, these are the databases for all this is very limited across the globe. Now, we understand that we want to improve the so-called stigma associated with ECT and the cognitive impairment. We want to reduce that. That is where we are trying to improve the different technologies about ECT, and one of them being the placement of various electrodes for the ECT. And we all understand are very much aware about the so-called bitemporal placement of the electrodes, but right unilateral and bifrontal have emerged over the years. And what we understand that the bifrontal and right unilateral have less of cognitive impairment compared to the bitemporal, but it is also now well understood that if patient is not responding to right unilateral or bifrontal, you can still go back to the bitemporal ECT to take care of your patient. And the newer techniques like the focal electrically administered seizure therapy, where you specifically focused on the frontal lobe, and the basic focus is that you are using not a so-called, does it work? Yeah, you are only using unidirectional ultra brief pulses compared to the bidirectional pulses, and the so-called the stimulus is delivered at a very focused frontal lobe, so that you are not going into the hippocampus and the medial temporal lobes, and that is where the chances of cognitive deficits are much lower. Coming to the other ECT parameters, how we look at. So, for that we need to have understanding about the seizure duration, the electric current, and the seizure threshold. So, there is a lot of, so we need to I hope that all of you understand the waveform, pulse width and frequency when you are administering ECT, and that overall normally the residents will understand the duration of the current, that how much current has to be given. They hardly talk about the pulse width and other things. That is why we need to understand these 4 things when you are giving ECT. And when we look at the data for seizure duration, again lot of research has gone on in terms of whether there is a relationship between the efficacy of ECT and total duration of seizure over the course. And there is some data to support that, but there is equally data that it does not support the total duration of seizures is important. Still the gold standard remains that 15 seconds of motoric seizures and 25 seconds of the EEG seizure. And again here the understanding should be very clear that the duration should be counted once the whole stimulus has been delivered, rather than counting it from the time when you administered the stimulus. Then understanding the importance of the post-ictal suppression. In India, in most part of the country, we do not use an EEG recording, and that is where we do not understand the importance of post-ictal suppression. But it is now very clear that if you need to do a EEG monitoring and evaluate the post-ictal suppression, and if the post-ictal suppression is better, the efficacy of ECT is better. So, that is where it should become as a practice that we do a EEG monitoring of the seizures for our patient. And the better the post-ictal suppression, you will have better ECT outcomes. And it has been seen that other treatment modalities, like when you are combining, when you are using so-called thiopentone, or when you are using antipsychotics like clozapine, they contribute to the higher post-ictal suppression, and that is why you see better response with ECT in these group of patients. And I think I spoke about that. So, moving to the next is the waveform. The sine wave ECT, people those who have administered the unmodified ECT understand that, but the current generation don't understand, and it's totally out of practice. But we understand that the so-called brief pulse and ultra brief pulse therapy, and the ultra brief pulse therapy, again you need to understand, is 0.2 to 0.3. Some people talk about up to 0.5, and but again the efficacy wise it is said to be similar, although you may require longer courses and has to use much higher than the seizure threshold, but it possibly leads to the lower cognitive deficits. And similarly, if you compare if you look at the data, how they compare. So the basic thing, again I would put it this way simply, that ultra brief pulse ECT gives similar efficacy if you give at a dose of higher the seizure threshold, maybe about 6 to 8 times. So this is where you have to understand how you are going about. If you are giving the ultra brief and so on, so what should be the stimulus above the threshold. Again, many times resident will just limit themselves to the seizure threshold and keep on giving ECTs and then say ECT is not working, but you have to give ECT beyond the seizure threshold to get its efficacy. Then understanding the importance of frequency. Again, normally if you look at the multiple places in India, most of us will give the so-called moderate frequency, but now there is a lot of data again emerging from countries like Australia, where we are talking about low frequency between 20 to 40, and again it has been seen that low frequency ECT actually is equally efficacious and leads to less cognitive deficits, because there is less crowding of the so-called electric current in the brain, and that is where there are less cognitive deficits with the low frequency ECT. Again, the issue is about what medication can we give, what not to give. Initially people talked about stopping the medications with ECT, but now a lot of data is emerging. I am just quoting few big sample size studies, that studies have shown that you can continue using antidepressants with ECT, and various classes of drugs have been evaluated, and there is some data to suggest, again I am not saying this is the so-called gold standard, maybe actually mirtazapine may help in improving the efficacy of ECT if you are combining that with ECT. And similarly for antipsychotic, again a lot of data is emerging, and you see that with low potency typical antipsychotics and clozapine, because of the post-ictal suppression or increasing the seizure duration, you may have better results. Now, coming to lithium, again this is one drug where we have to be very careful, and again a large sample size data suggests that use of lithium along with ECT has associated with immediate complication like delirium and the so-called more higher cognitive deficits, and these are more common in patients with unipolar depression compared to the bipolar depression and mania, and further the risk is much higher, the odds ratios are much higher for people who are elderly. So, it is always better to stop lithium while giving ECT, but other drugs can be continued. Now, coming to the use of anesthesia during ECT. So, we all understand that different anesthetic agents are being considered for use of ECT, but methotrexate is actually a problem where you get it or not get it. So, people across the country use different agents. In most centers in India, thiopentone still remains one of the choice, but people also use etomitate and propofol, and ketamine is now again coming, and we have people are using combination of propofol and ketamine in management of the anesthesia during the ECT. So, you need to understand how these affect the seizure threshold, and you need to choose the anesthetic agents again very carefully, so that, because if you are using that something which is increasing the seizure threshold, your stimulus may have to vary, and you have to again take care of that, and otherwise you will have more problems. So, but if no other choice, remember thiopentone is better and something which we are still using it. Now, coming to the issue about the maintenance ECT, which has been talked about, whether we can give maintenance ECT or not. The whole concept of maintenance, RTMS and DBS and everything has come from maintenance ECT, we need to remember that, and now we have the practice recommendations and very clear guidelines how to give maintenance ECT, and it is very now being understood that because of the high risk of relapse and whether you give medications after ECT. So, the data is emerging that if you give maintenance ECT also, it works better. So, and maintenance ECT does not lead to further worsening of the cognitive symptoms. That is where that just considering only medication, you can consider use of maintenance ECT, and we quite frequently use at our center. So, what is being suggested that if a patient has lot of treatment resistance, he is showing full remission with ECT, and if the patient is preferring to go for a maintenance ECT, we need to consider maintenance ECT in the group of patients who are willing to go for that. Next, moving, and how do you consider, how do you go about it? That initially you give ECT 3 times a week, then move to 2 times a week, then move to once a week, and then maybe shift to bi-weekly. And there is some data to suggest that you can titrate, you can decide depending on the response rate about the frequency in the maintenance phase. You can give between once in 10 days to maybe 1 month according to the response and how the patient is performing. But the patient should be reviewed every 3 months, and you should be rating the patient from time to time. Coming to the final thing which I was asked to cover is the stigma and advocacy. So, we all understand that people have tried to change the terminology associated with ECT, and there different names have been suggested for ECT over the years, but ultimately what is being seen that no names work better than ECT. So, electroconvulsive therapy. And when we look at the different kind of stigma, there is a lot of stigma because of the misinformation, and there are legitimate concerns also that many times psychiatrists administer ECT without telling the patient. So, there is a lot of so-called problems with that, and also there are issues about the cognitive deficits. So, we need to, as psychiatrists, when we are practicing ECT, we have to be very honest with our patient, disclose the full information about the side effects, and give them the option to choose the treatment rather than forcing them to take the treatment. But what we need to do to fight stigma against ECT, we need to make people aware about ECT at the undergraduate level, at the level of public level, that, and so-called how people are projecting ECT in various films and other things. So, these are the some things which we need to focus, and when we are administering ECT, we need to maintain good standards so that we are able to defend the treatment in a much better way. What are the new things emerging in relation to stigma? Now, we have more data to understand, like, because this again comes from the fact that people started talking about how the perioperative anxiety affects the outcome. So, we have evaluated the so-called pre-ECT anxiety and how does it affect the outcome, and the data again suggests that if person has a lot of pre-ECT anxiety, it leads to lower efficacy. That is why again we need to work on this, and we need to take care of anxiety of our patient and educate them about ECT before we go for ECT. And now we have specific ECT related anxiety questionnaires which you can use and plan your psychoeducation and interventions. And for the assessment of cognitive functions also, we have the specific now the instruments. If you look at that generic and specific instruments, but now we are coming with specific ECT related cognitive assessment instruments, and in that two commonly used instrument, one is the brief ECT cognitive screening, which is just basically 20 minus 1 and the months counted backward, and the other one has 30 item scoring, which takes care of the patient's views and also the caregiver views and the autobiographical memory in addition to the attention concentration. So, to conclude, ECT, as I put it, best treatment for treatment resistant severe mental disorder. No other treatment comes closer to that, and it still remains the gold standard. There is no match to the same. Thank you.
Thank you for that extremely lucid walk through history and totally into advances in ECT. We'll take questions now from the floor. Anybody? Since we have, yes. Yes.
Thank you, sir, for the great talk. I had a question regarding what is your experience with mortality in ECT, even though the prevalence is probably very less minuscule, but practically, and have you noted any particular points, because some clinicians say that cannabis users have a higher tendency of developing complications. So practically, What have you noticed, sir? And secondly, a lot of clinicians disclose to the patient that you are going to get ECTs, and some clinicians prefer to not say. So if you're any of the seniors and you could guide us on what to do in that case.
Yeah, thank you. Coming to your first question about the mortality, again, no on-table mortality. Okay. On-table recovery problem, only one group of patient. If you have not taken the history properly for organophosphorus intake, and if patient has taken organophosphorus recently and you end up giving ECT, pseudocolon stage will come into play and patient is not going to recover. So, that is on-table problem with ECT. Post ECT, again mortality, we have seen only in 2 patients out of, I would say, maybe 6,000, 8,000 patients which I have at least given ECT. Again, not my patient, that also I will put it, elderly with severe multiple comorbidities. So, you cannot attribute, and not that has occurred after about a week after the giving ECT. So, you cannot attribute that to the ECT. So, no direct ECT related mortality. Now, about whether to tell the patient whether he is receiving ECT or not, it is very clear that you tell openly to the patient that you are going to receive ECT. And the best thing is, this is where we stop, that you are going to receive ECT. The best thing to tell the patient is that you are going to receive a treatment which will be under anesthesia, you will not come to know about it, and it is not painful. And that treatment is known as ECT. People introduce ECT as झटका लगेगा या बिजली का इलाज कराना पड़ेगा, rather than first talking about the procedure and bringing what the end thing happens. So that when we give ECT also, giving the stimulus is the last thing. You will undergo medical evaluation, you will undergo anesthesia, it is not painful, and you will receive an electrical current for a few seconds. And if you ask me what is my thing, I always tell my patient, if I develop the illness which you are suffering, I will only go for ECT. Straightforward.
Yeah, thank you. Under MHCA now, it would not be wise not to tell your patient. There is a separate consent form for ECT, separate consent form for anesthesia. So we have to follow those norms. And if you want to give ECT to a minor, there is a protocol to be followed with MHRB permission. So let's also play legally safe and be very clear. We are not doing anything wrong. I think part of the stigma comes from the fact that we ourselves don't want to talk about it as a procedure. And you know, although like Sandeep said, the nomenclature has changed, but I think FEAST is something which somehow is becoming more acceptable to people than ECT. I do not know if it's going to change. For us, it's just simple to say that even in pregnancy, ECT is safe, is one of the simplest examples you can give your patient, and then go ahead with it, right?
So one of the ways of approaching is to tell the patient that, look, you have these symptoms, that's taking away the pleasure out of your life, because your brain is not functioning very well. So we want your brain to become more spontaneous and feel good about it. Tablets are not working as well as they should have, and why prolong your morbidity? Take this, what you will receive is an injection. What will be done is that your brain will be stimulated electrically, and Google says ECT is safe. So that's another thing that helps.
For a change. Yes, Darpan. The question was, where do you see artificial intelligence?
So, at present there is some data being generated based on the existing data and the machine learning to find out the predictors of ECT. So, by that technology, we are trying to generate the variables which can be picked up, and that can be used at the level of psychoeducation of the patient, that you have these factors in which ECT works, and at the same time clinician can also beforehand come to know whether to give ECT to this patient or not. We have reached to that level at this moment. Maybe with time we will have a better understanding.
So to make artificial intelligence tells you everything other than the machine, the stimulus, that has no artificial intelligence.
Yeah.
That's pure the psychiatrist's fingers. But otherwise it helps you to evaluate and assess and find indication.
Even with a very low mortality, what AI is going to do is synthesize the patient information and say that due to these comorbidities, the risk may be stratified as minimal, mild, moderate, severe, if I'm not mistaken. So
the procedure itself has no AI in it.
Yes, yes.
Please.
Hello, sir. Thank you for the talk. You mentioned briefly about clozapine, that it of course lowers the seizure threshold. But any guidance about the combination of ECT with clozapine, because it also is known to cause some more confusion. So how do we deal with that?
So the simpler things to do is when you are giving ECT in a patient on clozapine, what I do is reduce the dose by about 1/3 on which the patient is on clozapine, and then give ECT the acute course, and then get back to the older dose of clozapine. If I have to give maintenance, on maintenance I will maintain the highest dose of clozapine. That is basically done to reduce the risk of delirium, because of the anticholinergic properties of the clozapine, which is high, it leads to the increases the risk of delirium and confusion. But in our data, whatever we have seen how it works, we hardly see patients on combination of ECT and clozapine reporting higher cognitive deficit compared to those not on ECT. So practically it does not make much of difference in terms of cognitive deficit.
Do you also
just a rider here? The data on clozapine, ECT and its complication is not from Indian sources.
No, sir.
Where the average I'm sorry, I beg your pardon.
Sir.
Where the average dose is from the West is much higher than the dose that we use here. His data is safe because the average dose of clozapine that we use in India is much lesser than the average dose that is used there. So his average dose also was
about 260, 250.
220, yeah. It's not in
Yeah, so we also have used up to 200 or so. You can go down.
The dose that you can halve it, that's okay. But all the complications that they mention is at the dose that Americans and Britishers use, which is a much higher dose of clozapine.
So do you also see that with chlorpromazine?
Yeah, so chlorpromazine at times you need to understand when you are managing a patient with agitation, many people will prefer to use haloperidol. What we do is we prefer to use chlorpromazine. If you are considering ECT, either it takes care of the agitation and the patient does not require ECT, or if he requires, his seizure threshold comes down. So that is how we play with chlorpromazine in the ECT course.
But about the confusion, do you see that with?
Because we do not go again beyond about 200 to 300 with chlorpromazine. Again, although it is recommended up to 1000, so maximum we will go about 300. But at 300, many times patients no more require ECT.
Thank you, sir.
Yep.
Just one question. Yeah. Anxiety and pre-ECT anxiety. Would you advise benzodiazepines pre-ECT for anxiety?
Sir, the anxiety is basically, again, when we look at the data which is emerging, it is specific to that will I develop cognitive deficit, whether I will develop side effects, will I improve or not. So in those kind of cognitions, possibly the benzodiazepines are not going to take care much.
That's right. And the anticonvulsant action of benzodiazepines is another consideration.
Yeah.
Sir, yeah, you have the largest experience of ECTs.
Sir.
Last question from the way, sir.
Last comment.
Sir's comment, yes.
This is not my experience, but the presentation in Bombay Psychiatric Society, one by Dr. Dungaji, who is no more, and Dr. Patkar. Dr. Patkar had presented in Bombay Psychiatric Society ECT in a hepatic coma patient, where in Nair hospital all other treatment has failed. Patient was in the coma, and like he thought it could be like a catatonic schizophrenia, but patient was in hepatic coma. He gave ECTs and patient recovered. One case reported by Dr. Dungaji, where the patient was operated, or he had probably one side hemisphere was totally damaged. Patient had a psychiatric symptoms and he gave unilateral ECT and the patient recovered. So there are some sort of a miracles which has happened with the ECTs.
Thank you, sir, for those comments. I would just say that that's why I said there are no absolute contraindications for ECT, and it is the best treatment in psychiatry. There is no match to it.
You would have read Kalinowski's old reference, where he had said ECT is almost sarvagun sampanna. And everything it can be given.
Yes.
What do you have to say to that?
Totally agree, sir. ECT, if nothing works, ECT is definitely going to work. And ECT actually has, if you remember, if you want to remember, in psychiatry there are only 3 things. That is, ECT means ECT, clozapine, and tricyclic. If you have armamentarium, these 3 things, plus lithium, you don't require anything else.
At a very personal level, I had met Kalinowski before I joined medical college. And I still remember the way he talked and presented and said ECT is the treatment of choice. I joined medical college almost thinking that I'm going to be just giving ECT and nothing else.
And we are very fortunate in India that there is so much use of ECT and we should not shy away from it. Thank you very much for that excellent talk and discussion.
Thank you, sir. May I please request the chairpersons and Prashant sir to please felicitate Sandeep sir. Thank you. So moving on to the last session for today, tDCS, tACS, and vagal nerve stimulation in psychiatry, and by Professor Kaviraja Odupa, sir. May I please request the chairpersons to introduce, sir?
So welcome, Dr. Kaviraj. He's the professor of neurology in NIMHANS and an expert in movement disorders, neurophysiology, and neuromodulation. Has a lot of research on basic movement disorders, which includes Parkinson's, dystonia, and other neurological conditions, as well as neuroplasticity. And right now, research interests include induction of neuroplasticity by combining DBS with rTMS, and of course, the interaction between excitatory and inhibitory neural networks, as well as alterations in those networks. So it's very interesting, and we are really looking forward to seeing what you bring to us today in the other neuromodulatory techniques, which includes the 3 that Prajakta mentioned. Thank you for coming to Mumbai and being with us in BPS.
Thank you, madam, for that kind introduction. I would like to make a couple of disclosures. I am not a neurologist, not a psychiatrist. I'm a neurophysiologist, and I'm the last batsman here with the galaxies of batsmen who scored centuries after centuries. So, but I think I can take shelter under Dhoni, who comes as a pinch hitter, and I have the 3 bats now: tDCS, tACS, and taVNS. So hopefully one of the bats would click. Again, I would like to thank the Bombay Psychiatric Society for giving me this opportunity, and I would like to talk on few of the basics as the mechanism of these modes of stimulation and its indications in psychiatric conditions, though most of these indications are still investigational, off-label use, so needs ethics approval if you are doing a study, but we need more data from India. And some of the works done at our center, we know we need more personalized neuromodulation even in these modalities. So we talked about different modes of stimulation, TMS, investigative TMS using single and paired pulse stimulation, the patterned stimuli, RTMS. But what I am going to talk all these 3 modes, that is electrical stimulating the brain. Of course, it is not electroconvulsive therapy, but it is stimulating the superficial parts of the brain. Thereby we can modulate the neuronal circuits, and the taVNS, which is the new mode of stimulation, where we are stimulating the transcutaneous auricular vagal nerve stimulation. So briefly talk on that as well. So we have different modes, and in addition to the electrical and the magnetic, which we discussed a lot, we have the ultrasound and also the photobiomodulation, which is a transcranial stimulation using infrared light is also picking up. So these are all the investigations going on. So I'll be sticking on to these three modes of tDCS, tACS and taVNS. So we also discussed some of these aspects, mainly how the plasticity, neuronal plasticity is achieved by giving these modes, the LTP-like. Of course, classical LTP is discussed in the slice preparations in the hippocampal slices. So when we are using it in system level, we should use the term LTP-like or LTD-like. It is the tDCS, the anodal one, which will have LTP-like effects, whereas the cathodal would have the LTD-like effects. These are all the clinical utility of NIBS, and if you are sticking to these three, most of it are investigational yet. Off-label use, we need to get approval from the institutional ethics committee. But of course, lots of private clinics, they are offering these based on the investigational or humanitarian indications. So briefly talking on to the tDCS, basically it is giving transcranial direct current. Direct in the sense we are using a battery and we are stimulating a specific region of the scalp, and there would be anode and the cathode, and the whole idea is current flows between these anodal and cathodal whenever we stimulate the direct pulse. That is, there is an upstroke and a downstroke, and there would be plateau where we need to stimulate with the specific parameters. It's non-invasive as well as non-convulsive, so no side effects as such, not many side effects as such. And the stimulation parameters, mainly it is the intensity of the current or the amplitude, which generally 2 to 3 millivolts is the maximum, otherwise the subject would have lots of side effects. And these effects would last for 1 hour, and when we are giving it on a cumulative basis, it would have the clinical benefits would get added up. And these are all some of the physics. Basically here the amplitude of the current is constant, voltage and the resistance or the impedance would change depending on the tissue that we are stimulating, and generally this amplitude is kept at a maximum strength of around 2 to 2.5 millivolts and milliamperes, I mean. And the stimulus duration again around 20 minutes is recommended. So this is the idea, the cathode and the anode, and we stimulate using this tDCS stimulator. Wherever we keep this electrode anode, the whole idea is giving charges, positive charges there, and that would cause the depolarization kind of effects. Again, compared to the TMS, there won't be any visible twitch. So here there would be changes in the resting membrane potential per se, towards depolarization or hyperpolarization. There is no action potential generation, but this per se would change the neuronal excitability, and when it is given as a continuum over the period, it would change the neuro excitability or the plasticity related changes. And studies have shown with TMS you can change the MEP amplitude, which is the direct measure of cortical excitability. Whenever you give anodal, there would be increase in the excitability, and whenever you give cathodal, there would be decrease in the excitability, LTP-like or LTD-like effects. So again, we can use this in conditions in which we need to increase the excitability. Say for example, on depression we have seen left dorsolateral prefrontal cortex is usually the target, so the anodal tDCS is given there, whereas auditory hallucination in schizophrenia where the temporoparietal joint where we use the cathodal tDCS to reduce the auditory hallucinations. So in psychiatry, major depressive disorder is the commonest indication, and it's comparable to the antidepressant effects of 20 mg of fluoxetine. In bipolar disorders, we use left prefrontal anodal stimulation compared to that of the depression. In schizophrenia, as I told, on to the left temporoparietal region. Substance use disorder, again, we use the DLPFC, and even anxiety disorders, tDCS over DLPFC has shown beneficial effects. Again, these, when we are using it, it's always with the medication. It is not exclusive use of these modalities. It will have add-on effects with the medications. These are all the different regions where we use DLPFC or left TPJ as the cathode in schizophrenia, and other regions depending on the pathology we are using different areas of stimulation. And we go back, this is the classical cathode and anode. Nowadays we have what is called as high definition tDCS. High definition in the sense we need to give focal stimulation to that particular area. Say for example, we are stimulating in depression left DLPFC, we can use this kind of montage where anode or the cathode would be in the center, surrounded by these. Of course, HD tDCS would be, the equipment would be more costlier compared to the classic tDCS. And in depression per se, it is definitely better than sham. Studies have shown that, and these are indicated in patients with moderate to severe without suicidality, and it is better to use in patients having shown some kind of medical refractory depression, and its role is an augmentation or in resistant depression, and as we have seen in pregnancy, elderly or medical comorbidities, and definitely it is inferior efficacy as monotherapy. These are some of the studies in which they have used tDCS device as a home-based approach, and it is remotely supervised and supported multi-channel home-based tDCS is safe and feasible. Even the areas where they stimulate, studies have shown even in bipolar depression, the stimulation of anodal on F3, cathodal on F4 have shown benefits. These are all some of the meta-analysis data, and usually a long-term follow-up, if you see, the effects would last around 4 weeks to 3 months. I guess there is one more study in which they have seen the maximal peak results around 6 weeks of therapy compared to that of the sham stimulation, and so they might require that maintenance sessions. Of course, these patients would be on medications. These are given as an add-on therapy. In schizophrenia, again, studies have shown, especially with the auditory hallucinations, rating scales have shown a significant difference over time with cathodal tDCS. And even with the negative symptoms, meta-analysis have shown its efficacy in terms of cognitive benefits. Also, some of the benefits have been shown. So standard operating procedure of home-based tDCS is safe and effective administration, mainly based on its cost effectiveness. Acceptance is better, long-term application and tolerability, and portability. You can give that device to the patients or the family to give that, and these are all the indications or its efficacy in substance abuse disorder or substance dependence, and different areas have been tried, and different cognitive as well as the behavioral measures have been tried with tDCS. In general, reduced craving at rest and increased propensity for risk-taking marijuana users and trend for more relapse has shown with various substance dependence disorders. And again, the studies even with the TMS and tDCS, basically it has on different measures, not just the craving, relapse prevention, cognitive dysfunction, even post-operative pain management. This can be used, of course, with the depression and anxiety and other co-occurring substance use. Even with pediatric psychiatric usage, there have been increase in literature in this particular autism spectrum disorders, but we need more data on that, especially the heterogeneity of the protocols and long-term impact of tDCS on neuroplasticity in developing brain. We don't know much about that, so we need more data before using it in autism or autism spectrum disorders, though there are studies, meta-analysis also showed some benefits. Again, autism spectrum disorder, this is one of the meta-analysis showed anodal on F3 and cathodal on, he has shown improved autistic symptoms compared to that of the sham controls. Even its efficacy, since including pregnant women or maternal fetal postpartum adverse effects have not been shown, so it is quite safe, its utility. And again, active tDCS is associated with the small but significantly increased risk of the mania, emergent mania, compared to that of the sham, that we need to keep it in our mind when we are giving that. So in nutshell, we can use in non-treatment resistant depression, addiction and craving, alcohol, nicotine, cocaine. Some data is there, and auditory hallucinations in schizophrenia. It is showing positive effects. Of course, we need more studies in OCD and ADHD and other autism spectrum disorders. So in nutshell, compared to other modalities that we discussed, being cheap, no need for anesthesia, not at all invasive, and it is portable. It ticks all the boxes, but we need more data from India, more multicentric studies to show its efficacy, especially its home-based application, scalability, and other things we need to work out further. tACS, transcranial alternating current stimulus, only difference being here, instead of direct current, instead of a cell, we are using alternating current, where the cathode polarity is not the importance, it is the frequency. So we can give it in different frequencies. Basically, we know our brain, it functions with different frequencies. So alteration in these frequency could be one of the pathophysiological factors. So by giving those particular frequency, we can fix some of these idea. But again, we need more data on its delivery and its efficacy in various disorders. Of course, we have a few data on that, and here the whole idea is it orients the neuronal firing rates, and the spike timing is affected, not the direct action potential. So again, compared to that of the tDCS, where the constant direct current is passed, here it is sinusoidal alternating current. Here we have the specific polarities, anodal or cathodal, whereas in tACS it is the frequency that matters. And a shift of the membrane, as I told, it goes to depolarized or hyperpolarized range, whereas here it is the rhythmic membrane polarization. It's a spike timing dependent kind of plasticity, and it changes the cortical excitability, whereas the tACS, it modulates the oscillatory synchrony, the firing patterns of the membranes. The plasticity or the motor excitability is changed with tDCS, whereas with tACS, it is the brain rhythms or phase entertainment. So it has been, researchers been on ongoing in ADHD, dementia, depression, OCD, and schizophrenia. These are all the different indications, and a few studies and meta-analysis have been out, but we need more data. And the other important pattern in tACS is this temporal interference pattern. Basically, instead of giving say just 10 hertz of frequency, we can give the 2 kilohertz and 2.01. So the difference between these two would be in 10 hertz. So thereby giving that kind of temporal interference pattern, we will be able to go more in depth and cause the phase synchronization, and this has been tried in various conditions. Of course, even with Alzheimer's and primary progressive aphasia, these things have been done. But problem with that challenge is there is optimal target for stimulation is not clear, optimal stimulation parameters also not clear, there is heterogeneity of protocols, lack of large scale trials, so we need to necessarily target particular brain areas to treat specific symptoms, and one design doesn't fit to all. That's very much with these modalities of tDCS and tACS. We need more studies. Lastly, talking on to the tAVNS. So there are various modalities with which the vagus have been tried. Neurosurgery colleagues, of course, they implant VNS, vagal nerve stimulator, to the cervical region of vagus. That is a kind of treatment for refractory epilepsy, migraine, even in depression. But these kind of implant on the surface, onto the tragus, you can stimulate, and that is known as transcutaneous auricular vagal nerve stimulation. That directly activates the vagal. Vagal, of course, its involvement in various polyvagal theory has been proposed as the involvement of the vagus. So it has been tried in multiple disorders, neuropsychiatric disorders, and also there are lots of meta-analysis of tAVNS use. We need the optimal functioning of the vagus, which is very much important. And in cluster headache, of course, when we are targeting vagus, it is the afferent, which is almost 80%, which carries the information from the thoraco-abdominal viscera to the brain, and that we are targeting, not the efferent to the cardia and other regions. That's how we need to give specific frequency of stimulation around 25 to 30 hertz, which acts that. And in nutshell, so there are lots of indication. This is in general, but most of it are still in investigation. So depression and anxiety is the kind of disorder which can be targeted by any of these. Of course, there are some specific utility of these needs to be further investigated. So in terms of side effects, tDCS would have some tingling sensation, skin burns or redness, mania or the hypomania and depression, so we need to look for that, and others painful perception of the phosphines, and tAVNS bradycardia, so we need to control the cardiac rhythms. I won't go into the details of the studies that being done at our centers, but I will talk on some of the newer recent studies in which what we have shown, of course, with the tAVNS we can do EEG as well as the heart rate variability measures. So that would give us how the cutaneous stimulation of the auricle would have effects on EEG as well as the heart rate variability related changes. We need to have further utility of this in various psychiatric conditions, mainly in depression. Lots of ongoing studies are there. Of course, it is well tolerated things. There will be changes in both HRV as well as in EEG. I'll just take a couple of minutes here. So one important thing is the personalized stimulation. There is kind of closed loop kind of thing. So we need to get the data, what's happening in the brain, we need to know based on EEG or imaging modalities, then we need to specifically target that. This is what is being done in neurosurgery, those kind of personalized stimulation. Even in terms of tDCS, tACS or taVNS, we need to do this kind of modalities. We are doing that with, say, gamma frequencies in hallucinations in schizophrenia and also in aphasia patients based on the imaging modalities. And we need to understand what's going on in the brain, the pathophysiology. But more than that, we need more data from India, especially using these non-invasive modalities of neurostimulation. And we need more multicentric trials to get more data in various indications. With that, I'd like to thank you all for your kind attention, and I would like to thank our collaborators and our institution. Thank you.
Thank you. I think we rushed you through a little bit of it, but very interesting data. And I think what's important is that this is going out of the clinic and into the home. A lot of what you have presented is going to become personalized and something that everybody can probably carry with them and do themselves, which is going to be revolutionary if it really, really happens. So questions from the floor?
An interesting aspect is auditory hallucinations, which are otherwise so treatment resistant.
Yes.
You have got great data on it.
Yes.
Yes, Jalpa.
I believe NIMHANS has their own tDCS, which they have invented. And I want to know about the difference between the usage of that, and these days you get some online stimulation devices also, where you carry the personalization in the clinician's office. I think that monitor is, and you can monitor how much current the patient receives. So what is advisable? What is the difference? What is better?
Yeah, of course, it's Dr. Venkat. He's the one who has developed this device in collaboration with the DRDO. I think it is now available for commercial use. I'm not very sure about that. But of course, we need more heads-on data compared to the available literatures using those specific. That's why I've written, we need more such collaboration with the technical team and the clinicians, and we need to develop those kind of indigenous devices rather than, of course, market. There are so many things are available. We can't comment on what's available in the market, but whatever available like Soltrex devices or which are considered to be standard devices, we need more head-on comparison between these devices, and we need more data on that.
And sorry, I didn't get the vagal nerve stimulation, which is non-invasive. How does it work? Where is it put? I didn't get that, sorry.
Okay, so this, the auricular branch of vagus. So it has supply over this tragus area, and studies have shown stimulating this part. So it is a kind of clip kind of device which is kept onto the tragus. So any other regions it is supplied by the trigeminal or facial other parts, whereas this portion is supplied by vagus. And there by we can even see when we are stimulating, you can continuously record the heart rate variability measures, which are the direct index of how much the vagal activation is happening, and those are all the studies going on.
Any other questions from the floor?
I think we can take them up at the panel discussion now.
Okay, thank you. Thank you very much for that informative talk.
Thank you, sir. May I please request the chairpersons and Prashant Shah, sir, to felicitate our speaker. So because we've really overshot time, we've decided to cancel our panel discussion because I'm sure everyone's really hungry. Before that, I would request Prashant Shah sir and Dr. Paresh Doshi sir to please felicitate both of our chairpersons. Thank you. Welcome, ma'am. Thank you, Vaya sir, for almost moderating the whole of today's session. Thank you so much. Sir, a photo, sir. Sir, a photo. Thank you. Thank you, sir. Thank you, ma'am. So as we come to the end of today's program, I think we've really woken up to this new dawn of this new era of neuromodulation, and I'm sure we're all going away today with being more comfortable and more confident of pulling neuromodulation closer to our clinical practice. And thank you all for being there in such amazing numbers. We were really overwhelmed by the response that we got for today's session. We would also like to thank all the esteemed speakers, our chairpersons, and Vaya sir and Paresh Doshi sir for really pushing us and encouraging us to do this amazing CME with outstanding attendance. So thank you all for being here. We would also like to thank Intas and Mr. Prabhakar for putting up such amazing arrangements, and also Holiday Inn for giving us this venue and hosting us here. So thank you all. It was wonderful having you here today. Bye.